Good morning, everyone. Welcome to today's session on drugs to reduce hyperglycemia. In our previous classes, we had dealt with diabetes mellitus, its pathogenesis, classification of diabetes, lifestyle modifications, diet, and exercise prescription in diabetes. When lifestyle modification fails to bring about glycemic control, we need to resort to drugs to decrease the blood sugar level. Now, you would have noticed that we have not classified these as oral anti-diabetic drugs or oral hypoglycemic agents, but as drugs to reduce hyperglycemia. Oral hypoglycemic agents or OHAs were previous terms which are used, but our aim is not to induce hypoglycemia but to attain euglycemia. Hence, oral anti-diabetic drugs are the better term which are used for oral agents. But here we are dealing with both oral as well as parenteral agents for reducing hyperglycemia. Broadly, they can be classified into 9 as biguanides, sulfonylureas, meglitide analogs, thiazolidinediones, alpha glucosidase inhibitors, DPP4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and insulin. The first group of drugs are biguanides, and the classical example being metformin. So when you learn about diabetes, it's important to know metformin because it is a key component or key player in diabetes. Every patient who is a diabetic should be on metformin unless there is a contraindication. So it's the first line therapy in type 2 diabetics, and also in obese type 1 diabetic patients we use metformin along with insulin because of its effect on reducing weight. So it is basically an insulin sensitizer, meaning it helps to utilize the insulin that is already produced by the patient, and it helps in the tissue utilization. The main side effects are GI, that's diarrhea, abdominal cramps, bloating, and nausea, GI irritation. So it is basically an insulin sensitizer. It decreases the hepatic gluconeogenesis. It interferes with the mitochondrial chain, and it increases the glucose utilization in muscle and fat. We can use metformin in an initial dose of 500 milligram BD, which can be hiked up to 1 gram BD. That's a maximum dose of 2 gram per day. Metformin is contraindicated in patients with chronic kidney disease with an eGFR of less than 30 ml per minute per 1.73 meter square. It should also be omitted in patients who present with conditions in which you are expecting an acute kidney injury, like a febrile illness like leptospirosis, where you are expecting an acute kidney injury because it increases the risk of lactic acidosis. Lactic acidosis is a rare but life-threatening complication of adverse effect of metformin, and this can be aggravated in the setting of an acute kidney injury. It is also contraindicated in patients with significantly impaired hepatic function and in those whom there is binge drinking of alcohol or in whom the risk of lactic acidosis is significantly increased. So these three conditions, like patients with acute kidney injury, with severe hepatic impairment, and with excessive alcohol intake, the risk of lactic acidosis is increased, and therefore metformin has to be withheld or stopped. The second group of drugs are sulfonylureas. Sulfonylureas are insulin secretagogues. So as you know, in diabetes, you have a relative insulin deficiency, either an insulin deficiency or a decreased utilization of the available insulin due to insulin resistance. So sulfonylureas are secretagogues. It increases the production of insulin from the available beta cells of the patient. So they promote pancreatic beta cell insulin secretion. So there is a hyperinsulinemia. So what you have to understand at the outset is any drug which produces hyperinsulinemia will produce weight gain and also can produce increased fluid retention. The classical example of a sulfonylurea is glimepiride. Other examples being glycoside, glipizide, glibenclamide. So it's important to know the names of these drugs, the generic names of these drugs, because when you know the brand names, if you are not familiar with the brands, then the chances of a prescribing error is very high, and therefore it's important to know the generic names and their doses. So glimepiride is the most commonly used sulfonylurea, which you would have come across the prescriptions that you had gone through. So sulfonylureas act by closing the pancreatic beta cell ATP sensitive potassium channel. It decreases the potassium efflux, which ultimately triggers insulin secretion. Meglitinides like rapaglinide or natiglinide also work in this way, and although short acting, are essentially sulfonylurea like drugs. So this is another group of drugs which are also secretagogues. So the mode of action is pancreatic as well as extrapancreatic. In pancreatic, it's at least 30% of the beta cells are essential for these sulfonylureas to act. They act on the sulfonylurea receptors on the beta cell membranes, decrease the conductance of potassium channels, increase calcium influx. So they act on the ATP sensitive potassium channels. In extrapancreatic, they sensitize target tissues like liver, skeletal muscles, and improve translation of receptor activation. The adverse effects, as you know, is hyperinsulinemia producing hypoglycemia. So the chances of hypoglycemia are high with sulfonylureas as compared to biguanides. There are rare hypersensitivity reactions to sulfonylureas, and also nausea, vomiting, flatulence, diarrhea, persistence, headache, paresthesia, weight gain. So the most important adverse effects are hypoglycemia and weight gain. So the drug prescription or the dose prescription has to be taken care of when you prescribe sulfonylureas, as they can produce hypoglycemia. So recommendation is to use sulfonylureas as first line oral agents in patients who are not overweight, who are intolerant of or have contraindications to metformin. So metformin is the first drug to be started in a diabetic patient, and sulfonylureas are add-on drugs. And in patients who cannot tolerate metformin, sulfonylureas become the first line agents. They lower blood glucose, and also there are lower microvascular complications of diabetes in patients in whom we use sulfonylureas. But the adverse effects are hypoglycemia and weight gain. The third group of drugs are alpha glucosidase inhibitors. As the name suggests, these are inhibitors of the alpha glucosidase enzyme. Alpha glucosidase inhibitors delay carbohydrate absorption in the gut by inhibiting the disaccharidases. So these drugs are taken along with meal. So the patients are advised to chew these tablets along with the meal, because they have to act in the intestine by reducing the absorption of the carbohydrates by inhibiting the disaccharidases. They lower the postprandial blood glucose and modestly improve the overall glycemic control. So by decreasing the glucose absorption, they reduce, or carbohydrate absorption, they reduce the postprandial blood sugar. They can be combined with the sulfonylurea. The main side effects are flatulence, abdominal bloating, and diarrhea. And flatulence and abdominal bloating, GI upset, can be very much distressing in some patients, and that might result in stopping alpha glucosidase inhibitors. Examples are acarbose, voglibose, miglitol. So they are oral glucose lowering agents that specifically inhibit alpha glucosidase in the brush border of the small intestine. Can be used as monotherapy for treatment of patients with type 2 diabetes if tolerated. The next group is thiazolidine diones. These are also called TZDs or glitazones or PPAR gamma agonists. These bind and activate the peroxisome proliferator activated receptor gamma, that's a PPAR gamma, which is a nuclear receptor present mainly in the adipose tissue, which regulates the expression of several genes involved in metabolism. Glitazones are also basically insulin sensitizers. They don't produce hyperinsulinemia, but they utilize or increases the peripheral utilization of the available insulin, and thus bring about a lower blood sugar level. They enhance the actions of the endogenous insulin, both directly in the adipose cells and indirectly by altering release of adipokines such as adiponectin, which alter insulin sensitivity in the liver. So plasma insulin concentrations are not increased and hypoglycemia does not occur. The classical example of glitazones are pioglitazone and rosiglitazone. They also increase the pre-adipocyte differentiation, resulting in an increase in fat mass and weight. So these are agonists of the PPAR gamma and thus bring about the action in reducing the blood sugar. Pioglitazones also have got a beneficial effect in NASH and in reducing fatty liver. It's usually added to metformin or with or without sulfonylurea therapy. Or it can also be combined with insulin therapy. The combination of insulin and thiazolidine has an adverse effect in the form of fluid retention, and therefore it can produce weight gain and also increases the risk of cardiac failure in CAD patients. There is also an increased risk to produce bladder cancer, and once pioglitazone was withdrawn from the market because of the increased incidence of bladder cancer, but later it was again reintroduced at a lower dose of 7.5 mg per day. There are also increased risk of fractures associated with glitazones. Now, going to a group of drugs which entirely uses a separate mechanism of action. The two group of drugs are combined under incretin based therapies. These are the GLP-1 receptor agonists and the DPP-4 inhibitors. So what are incretins, or what is the incretin effect? It is seen that when we give a glucose challenge, IV and oral, the amount of insulin produced is higher with oral glucose challenge than with IV glucose. This is because of the production of certain hormones, the incretin hormones, primarily the glucagon-like peptide 1, GLP-1, and the gastric inhibitory polypeptide, GIP, which act to potentiate the insulin secretion. So this effect is called incretin effect. The effect of the incretin hormones to increase the insulin production on after an glucose meal. These hormones are rapidly broken down by an enzyme called DPP-4, dipeptidyl peptidase 4. So this is the normal metabolism of incretins. So when we take with the incretin effect is the augmentation of insulin secretion seen when a glucose stimulus is given orally rather than intravenously, and reflects the release of incretin peptides from the gut. The incretin effect is seen to be diminished in type 2 diabetes, and this has stimulated the development of the two incretin based therapeutic approaches, that is a GLP-1 agonist. So GLP-1 increases insulin secretion. So an agonist or a molecule similar to GLP-1 can increase insulin secretion, or the second strategy could be to reduce the breakdown of GLP-1 and GIP, that is the enzyme DPP-4 is responsible for their degradation. So if we inhibit DPP-4, again you can increase the amount of insulin produced and thus bring about a lower blood sugar level. So this picture again shows the insulin secretion on when there is a glucose stimulus. So there is a basal secretion. There is a first phase of increased insulin secretion, as you see in picture A. And in B, you see the incretin effect. After intravenous glucose, the amount of insulin produced is far less as compared to after oral glucose. In this picture again, you can see that there is an incretin effect which produces an increased insulin on oral glucose, which is seen in the first graph in blue, which is the response to oral glucose as compared to the intravenous glucose, which is yellow. And this incretin effect is seen to be diminished in type 2 diabetic patients. So there is a decreased insulin production after an oral glucose as compared to a controlled subjects. So GLP-1, which is an incretin, upon ingestion of food, is secreted from the L cells in the jejunum and ileum, and it stimulates insulin secretion, suppresses glucagon secretion, it slows the gastric emptying and reduces food intake. The long-term effects which have been demonstrated are increases in beta cell mass, and it maintains the beta cell efficiency. GLP-1 receptor agonists, as the picture shows, are subcutaneous injections. So till now we were discussing about drugs which are taken orally, but GLP-1 receptor agonists are subcutaneous injections, examples being liraglutide, exenatide, lixisenatide. There is a mildly increased risk of pancreatitis with GLP-1 receptor agonists, but there is no hypoglycemia. The other group which utilizes again the incretin based therapy is the DPP4 inhibitors. The examples being sitagliptin, teneligliptin, vildagliptin and linagliptin. So here you can see when you take a mixed meal, a glucose, that's intestinal GLP-1 release, and this active GLP-1 is made inactive within 1 to 2 minutes by the DPP4 enzyme. So if we can inhibit this DPP4, there's a DPP4 inhibitor like sitagliptin or teneligliptin, it will maintain the active GLP-1, which will increase the insulin secretion and bring about a decreased function, a decreased blood sugar level. The effects of DPP4 inhibition are improved beta cell function, it decreases the glucagon secretion, insulin sensitivity, and it maintains the beta cell mass. Moving on to the next group of drugs, these are the SGL2 inhibitors. So this is another mechanism of action by which you can bring about a decreased blood sugar. That is the sodium and glucose transporter 2 in the kidney. The examples of SGLT2 inhibitors are dapagliflozin, empagliflozin and canagliflozin. Glucose is filtered freely in the renal glomeruli and reabsorbed in the proximal tubules. So SGLT2 is involved in reabsorption of glucose. Thus, if you inhibit this SGLT2, it results in approximately 25% of the filtered glucose not being reabsorbed with consequent glycosuria, and helps to lower blood glucose and results in calorie loss and subsequent weight loss. So you increase the glycosuria, you reduce the reabsorption of the filtered glucose by inhibiting the sodium and glucose transporter 2. But the adverse effect being glycosuria may lead to increased incidence of genital fungal infections. So in this picture you can see the SGLT2 in the proximal tubule is responsible for the reabsorption of glucose, which gets inhibited by these drugs. So this table gives you all the groups of drugs which are used to reduce blood glucose levels and their effects on the fasting blood glucose, postprandial blood glucose, the plasma insulin, body weight, cardiovascular benefits, risks of hypoglycemia and tolerability. So it's a very important table wherein you summarize all the effects of the drugs, and also it is based on these effects that you decide on the combination therapies that you will be using in a particular patient. So first you have the insulin, which reduces both postprandial as well as fasting glucose. It increases the plasma insulin level, thus it also increases body weight. There is definitely risk of hypoglycemia, but better tolerability provided the patient becomes willing to take insulin. There's an initial inertia to initiate on insulin, but once insulin is initiated, there's a better blood sugar control and reduced long-term complications of diabetes. Sulfonylureas and meglitins, as we have already learned, are secretagogues, and therefore they will increase the plasma insulin level. It will produce weight gain and it can produce hypoglycemia, but the tolerability is good. It reduces both fasting blood glucose as well as the postprandial blood glucose. Metformin is the drug which should be prescribed to every diabetic patient unless there is a contraindication. It reduces the plasma insulin. It is neutral on the body weight, or in some it even produces a weight loss because of its anorexic effect. But tolerability is the issue. There's only moderate tolerability with GI side effects, and in some patients you might even have to stop because of the gastric irritation. Alpha glucosidase inhibitors are again acting on the intestine by reducing the blood glucose absorption. It has more effects on the postprandial blood glucose level and it has to be taken along with the food. It reduces the plasma insulin levels. Body weight has not much use, and there's also a tolerability issue because it can produce flatulence and gastric irritation. Thiazolidinediones or the glitazones produces a decrease in the FBS as well as PPBS. It reduces the plasma insulin level, but it can produce fluid retention and therefore has to be used with caution in patients with cardiac failure or can precipitate cardiac failure. But it has got a cardiovascular benefit, probably, especially pioglitazone, and tolerability issue is moderate is there. DPP4 inhibitors or the gliptins are having an effect both on fasting as well as postprandial. It increases the plasma insulin levels by increasing the GLP-1, and there are no cardiovascular benefit but good tolerability. And GLP-1 receptor agonists like liraglutide also decreases the blood glucose levels, but it increases the plasma insulin, and there's cardiovascular benefit with GLP-1 receptor, but tolerability is again moderate. SGLT2 inhibitors produce glycosuria by inhibiting the SGLT2 receptor in the proximal tubules of the kidney, but glycosuria can lead to increased infections, and there is a cardiovascular benefit with SGLT2 inhibitors. So this table summarizes how you will choose which drug, because you have 9 groups of drugs already which we have learned, and there are also newer drugs which are coming up, and which drug to use in which patient, it can be a dilemma for the treating physician as well as the patient. So as you can see from the above, healthy eating, weight control, increased physical activity, and diabetes education or lifestyle modifications are the first line in diabetes management. And if you have to start on a monotherapy for a patient in whom you have not attained a proper glycemic control with a lifestyle modification, it is metformin. So it is the efficacy, hypoglycemia risk, weight gain, side effects, and cost which decide which drug which you will you choose. So efficacy wise, metformin has a very high efficacy, low risk of hypoglycemia. It is weight neutral or it can produce weight loss. Side effects are minimal, especially GI and rarely lactic acidosis. And it is a very cheap drug which is freely available, and therefore in every diabetic patients, unless there is a contraindication, you should have metformin in their prescription at a dose of 500 mg BD initially, which can be hiked up to 1 gram BD up to a maximum dose of 2 grams. With metformin and optimum dose of metformin, if you are not able to get a HbA1c target or good glycemic control, then we go for a dual therapy. Dual therapy, again, these are the factors that you will be looking for: the efficacy, hypoglycemia risk, weight, side effects, and cost. So you add metformin plus a new agent. It could be a sulfonylurea. Efficacy is high, but there is a moderate risk of hypoglycemia and also weight gain because of the sulfonylurea, and side effect is hypoglycemia again, and cost, it is low. And thiazolidinediones, again the same, it can again produce just a high efficacy, but it can produce edema, heart failure. So the profile of the patient, the underlying comorbidities of the patient also plays a role in when you are selecting a second drug which has to be added to metformin. DPP4 inhibitors are costly, otherwise the hypoglycemia risk is low, it's weight neutral, and the efficacy is also intermediate. SGLT2 inhibitors, again the cost is high, it can produce genitourinary infections and dehydration because of glycosuria, infection because of glycosuria. GLP-1 receptor agonists are very costly drugs, and it's also injections. And metformin plus insulin, basal insulin. So if you are not able because of the cost factors, then you might go for a metformin with a basal insulin, which will give a 24-hour coverage for your glycemic control. So if still the glycemic control is not attained, then you go for a triple therapy where you add metformin plus sulfonylurea plus a third drug, or you use a combination of these agents in the patient, but cause factors, efficacy factors, hypoglycemia risks, all these are taken into account when you go for a triple therapy. And eventually in long standing diabetes, when the beta cell function is lost and when you don't get adequate control with oral agents, you will have to add insulin along with metformin. So the combination injectable therapies should be metformin plus a basal insulin plus a mealtime insulin or a GLP-1 receptor agonist. So there are a lot of options available with newer drugs that have come up, but the older ones, that the sulfonylureas and metformin, still remain the gold standard or the cornerstones in treatment of diabetes, especially in a country like India, where cost is an important factor, because these drugs have to be taken daily, every monthly, so 30 days, 30 days of a month, and therefore the amount or the cost that is the cost burden of the cost on the patient should also be taken into account when you select drugs for a particular patient. So this is about the drugs which reduce hyperglycemia. And now we will go through the prescriptions that you had sent to me and see what all drugs that were being given for the patients that you had seen or your relatives. The first one was showing biphasic isophane insulin injection, and so it's a human mixture. It is basically 30 bar 70, which is a combination of basal insulin as a short acting insulin and also intermediate acting insulin. The second patient was taking telnimac M, which is metformin with tenligliptin. So gliptins are again DPP4 inhibitors, and metformin is a biguanide. Zoral M14. So here you can see a combination of OADs being used, that's glimepiride and metformin combination. Glimepiride at a dose of 1 milligram and metformin at a dose of 1 gram or 1000 milligram BD. So here you can see there is 2 grams of metformin being used, and again the patient is again also on Voglimac M, that is voglibose, glimepiride and metformin combination. So there are multiple drugs in multiple formulations and combinations used to reduce the pill burden. And so this patient is already on multiple OHAs, and if he or she is not on optimum control, then it should be better to add insulin for cost factor wise as well as for better glycemic control. The next patient is again on telnimac, that is tenligliptin and metformin, and also Geminor M, which is metformin and glimepiride. So glimepiride is a sulfonylurea, metformin is a biguanide, tenligliptin are gliptins, that is the DPP4 inhibitors. Metformin again is a biguanide. So here you can see the combinations being used, as we had discussed in the previous slide about combination therapies being used. Next patient is on metformin as well as glimepiride. So metformin is a biguanide. It is an insulin sensitizer, as someone has written, and glimepiride enhances the insulin secretagogue. The next patient is on glinase MF, which is glipizide, which is again a sulfonylurea, and metformin, which is a biguanide. So it's again a sulfonylurea metformin combination which is being used. The next patient is on diapride M1, which is again glimepiride plus metformin. So you can see most of the patients are on glimepiride and metformin. So it's a drug which is commonly used by us because it's cheap and easily available. And also the patient is on insulin twice a day. It's a biphasic isophane insulin twice a day. Our next patient is on insulin and glyciphage SR. So a patient on insulin, which is a mixed chart, twice a day, which is a combination of short acting intermediate acting insulin, and also she is on glyciphage. He is on glyciphage. Glyciphage is metformin. So mistake that has been written there, it's not a sulfonylurea, but it is a biguanide. It's an insulin sensitizer. So you see the glimepiride is a sulfonylurea, metformin is a biguanide, vildagliptin again it is a DPP4 inhibitor, telligliptin is a DPP4 inhibitor, voglibose is a alpha glucosidase inhibitor. You can see the utilization of the group of drugs that you have learned in patients in whom you have written the prescriptions. So this patient is a 73-year-old. She is on saxagliptin and metformin combination. Saxagliptin is again a DPP4 inhibitor. It's a costly drug. and glycomet GP1, which is a combination of metformin and glimepiride. Metformin being a biguanide and glimepiride a sulfonylurea. Our next patient is again on Zoril M1, which is glimepiride plus metformin. So you can see glimepiride and metformin combination being repeated for many patients that you have seen, and is also on vildagliptin and metformin combination, which is again a DPP4 inhibitor. Our next patient is on Gemmer DS2, which is glimepiride plus metformin, which is sulfonylurea and biguanide. So today we have learned about drugs which reduce hyperglycemia, and the last group is insulin, which we had dealt earlier. So always go through the drugs of your relatives, of your patients, and try to classify them into these groups and try to find out whether the combinations that they are using are optimum for them based on the factors that we have learned, that is efficacy, hypoglycemia risk, weight, whether it produces weight gain, side effects, and cost. Cost is a very important factor when you go for multiple therapies with oral agents, because multiple drugs, again the pill burden increases, again the factor of patient adhering to the drug combinations comes, and also the amount of beta cell which is available for these insulin sensitizers or the secretagogues to act. Thank you very much.